a patient who is having heart failure, multiple uterine fibroid and bleeding from those fibroids. So, having massive pervaginal bleed, and she is not suitable for a surgery, hysterectomy or myomectomy. So, that is the reason we are doing a uterine fibroid embolization to stop the vaginal bleeding and hence to basically take care of these fibroids and pervaginal bleed. Let us look at it. So, taking a right femoral arterial access, we are just going and table please. Right. So, we have Parvati today. Table please. Parvati is assisting me today, and then we have Prasad, who is the technologist, cath technologist. We have Gauri, and then we have smart boy Srinu. After a long time, so get me that. So, we will take a RUC, the Robertson uterine catheter, which will take. So, basically these uterine arteries are they are basically will go inside the common iliac artery, from their internal iliac artery, from there the anterior division into the uterine artery, and then we can occlude them by injecting polyvinyl alcohol particles. So, the best thing is patient is under local anesthesia and patient is absolutely conscious, cooperating with us, and table please. Table please. So, this is the very bad turn here. Give me a road map. Reset. So, we have a little difficult angulation here. Give me the wire. So, पारो जी और क्या खबर है? So, trying to navigate into the internal iliac, and we are there. Roadmap out. Table please. So, you can see it's a little tortuous. Table please. Perfect. Great. Table. One mag taku. Table. So, you can see this uterine artery basically very clearly seen. So, I hope this, can I have a roadmap on that? So I hope this RUC takes over. If not, we might have to take a microcatheter. Okay, give me the wire. Tell me. So generally, the RUC should be tracking on its own, which is not happening here, but I am already inside the uterine artery. कौन है पार्वती? I can navigate a cobra inside this. That will be easier for me because I'm not. Can I have the cobra?
Black cobra.
Regular. We can take a prograde if required. Hold the seat. Why are you sitting there? You don't have a RUCN? So once we are there in the uterine artery, in couple of moments, then we can start embolizing it. Order karo 4 months. Of course. I would love. So sometimes they are a little tough to navigate, but once we. Can I have a prograde there? So these are the tortuous iliac arteries, which are sometimes a little bit of trouble. Give me the prograde. Yes. 2.7. Yes, 2.7. So you can see very well the uterine blast. You take a microcatheter, get inside, and so we are taking a microcatheter inside the diagnostic catheter so that we have a very stable distal access. Exactly. So we are there. You can see the navigation. Beta Srinu. roadmap out, table. Perfect. Wonderful. Devada, PV particle there. Three hundred, 500, 250, 350 दे दो कोई problem नहीं. So you can see that our microcatheter was access the uterine artery. Right. So this is a very safe and simple procedure to take care of these fibroids, postpartum hemorrhages, and sometimes the adenomyosis which are bleeding a lot, so they can be really treated well, and you can really save a life in patients who are having intractable postpartum hemorrhage by going ahead and doing an embolization of uterine artery on both the sides. So I'm going ahead with, can I have a roadmap here? Thank you. Dextrose दरकार नहीं रे. Okay. Yeah, mom already changed. We can inject glue at the end if you want. So you can see these PVA particles are going, they will settle down into these abnormal blobs inside these fibroids. It's a very, very elegant procedure to do. The response to these procedures are really very good actually. Very atraumatic, simple, straightforward procedure with some experience is absolutely reproducible results. So you can see we are getting a very good stagnancy in those fibroids inside this uterus. So once we are done with this, so you should always be ready with a plan A, B, C. So here we had some challenge to go through these RUC, so we just changed it to Cobra, and that works superbly well. And C is basically 52, and we can certainly get rid of this problem. You want some glue to be injected, we can just close it up. Roadmap out. Not needed. We have already got a good one. Table. So you can see the fibroid blast is gone. So maybe you can do a little bit of proximal occlusion, 5, yeah. So there is no ovary and collaterals, nothing. It's very safe to go ahead and occlude so that the bleeding is really taken care of well. So within next few minutes, we will go to the right side of the uterine artery, and then so now let's take an injection and see what is the result we have achieved. So this is the fibroid which is there before embolization, and now this is showing, so no fibroid. So the fibroid blast has completely been taken care of. We will go to the right side now. Table, please. Ramanji, roadmap, give me the table. Give me the RUC, hold the seat, hold the seat, hold the seat. Okay. Put the RUC. So you can see that we went from the right side, went into the left side, common iliac, internal iliac, anterior division, uterine artery, occluded completely. Then we are coming back to the ipsilateral side, that's the right side, and let's try and get there. So it could be a little challenging. Order किया 5. Out. So as I said, it could be, table please. So again you can see the uterine artery which is supplying, road back. Wonderful. So let's get inside here Exactly. So one has to be really careful because the margins are it's a little quite tortuous one today. So you slowly make your way into that's another one. So here you can see this beautiful uterine artery here. So we need to get in there. So sometimes it can be little challenging. So this is the one. दिखा बेटा दिखा. Yeah. So okay, give me an oblique here. FC oblique. You can see this fibroid blast very well here. So let's go to the extreme lateral, right at this origin. Let's take a contra oblique. Better? So it's a proximal origin. Stop. Yeah, it's the proximal origin. And this is something has to be easy. Give me the wire. Yeah. So it can play a little bit of trick to you. So it's better you take so the wire will also help us straighten this catheter because we make a lot of twist and turn. Let's see where we are. Certainly not. Paraji, you should have stitched the sheath, ma. It's a really trouble for me. Epi? Is there. So let's slowly move. So otherwise what we do sometime here we can choose is what we do is, no, this is the external edit. So what we do, as I said, is we can take an opposite puncture and come out from the opposite side and then finish up the case. So it's not going where I want. How would RUC do? No? You don't have another RUC? Go to the store. Chudandi. This is, I'm not quite happy with this. La, la. It's right here. Prasad, now give me the wire. Prasad. Stop it. Na? Show me the last run. Continue. Show me the last run. Frame by frame. Back. Thank you. Paraji, give me the wire. Give me a roadmap. Reset. Take a Terimoyan. So, थोड़ा सा वेट करो. We are done. The sheath is trouble. Okay, bye. So there is a little tightness, so stenosis over there. So So you can have a little challenge sometime because these are tortuous vessels, but not really to worry. So we are there inside this uterine artery. So you can see that. So now let's do the angiogram of this uterine artery here. This is the ipsilateral right side uterine artery. You can see this abdominal spiral bloss. Can I have some more particles here?
Same, sir.
500, 700? So you have seen that we have gone from the right side. I went into the left side uterine artery, embolized, and then from the right side ipsilateral, taking a very acute turn, we went inside the internal iliac artery and into the uterine artery. And we are trying to embolize the right side, and that will complete the procedure. Five cc here. So diagnostic catheter. Roadmap here. So you inject under transubduction angiogram so that you understand where all the particles are going. So you can see a nice movement of these particles. So sometimes this catheterization causes spasm, and that's a good thing because you will have a real tight situation to inject forward. But if there is a spasm distally, then you can inject some nitroglycerin and reduce the spasm, create some vasodilatation. I am quite happy here. You're going right there where it is absolutely necessary. So once you keep the procedure short, simple, straightforward, your chances of having complications are really low. Hi, Vin. So now we will do an angiogram and we will see what we have achieved so far. See, this fibroid blast is completely gone. You happy? So we stop here. So the blast is gone. You can see that blast is completely gone from either side table. So we take out the RUC, inka paina chupichen beta, inka paina. Right. Wait. Kinda. So you should not be in a hurry. You can break the catheter, you can create complication after a successful procedure. So it's very important to do everything under vision. Thank you so much. So we just finished the uterine artery embolization for this lady who is 52, having massive pervaginal bleed and having a heart failure not suitable for any kind of anesthesia. It was done under local anesthesia from a single puncture in the groin, and the puncture will be closed with a perclose. So everything is fantastic. Tomorrow patient goes home. Thank you so much. And from our team, Parvati, Prasad, Gauri, and Stalisin. Thank you so much. Okay? हाँ थोड़ा लो बेटा पार्वती तेरा फोटो ले रहा है स्पेशल फोटो डिलीट कर देना क्या हाँ pause हाँ pause Are you sure you want to stop streaming? Are you sure you want to stop streaming?